Hello everyone, welcome back to the channel Microbial World. Today we will be studying about Entamoeba histolytica, an important pathogenic protozoan responsible for causing amoebiasis in humans. Understanding its morphology, pathogenesis, diagnosis and treatment is essential as amoebiasis remains a major public health problem in many developing countries. Entamoeba histolytica is a protozoan parasite that causes amoebiasis, a disease affecting the intestines and sometimes spreading to other organs like the liver, resulting in amoebic dysentery and liver abscess. It is transmitted through the fecal oral route, meaning infection occurs when a person consumes food or water contaminated with the cyst of the parasite. These cysts enter the body through unhygienic practices such as eating unwashed vegetables, drinking unsafe water, or due to poor sanitation facilities. Amoebiasis is most common in tropical and subtropical regions where overcrowding and improper waste disposal allows the parasite to spread easily. Entamoeba histolytica exists in three different forms: trophozoite, precyst and cyst forms, each playing a different role in infection. Trophozoite is the most active disease-causing form. It measures around 15 to 30 micrometers and moves using finger-like pseudopodia, which helps it to crawl and invade tissues. Its cytoplasm is differentiated into clear outer ectoplasm and an inner granular endoplasm. The nucleus is distinctive with a central karyosome and fine, evenly distributed peripheral chromatin. One of its most important features is erythrophagocytosis, meaning it engulfs and digests red blood cells. This feature is seen in the colon, tissue lesions, and intestinal ulcers. The precyst stage develops when trophozoites begin preparing to live outside the host. It measures 10 to 20 micrometers in size, and these forms are smaller, round or oval in shape and non-motile. It is formed by the condensation of cytoplasm and it serves as a transitional stage between trophozoite and cyst. Cyst is the infective stage responsible for transmission to new host. Cysts are 10 to 20 micrometers in size, round, and protected by a thick chitin wall which helps them to survive harsh conditions like chlorinated water and outside the body for several days. A matured cyst contains 4 nuclei and chromatoid bodies which are bar-shaped structures seen during development. These cysts are passed out in feces and infects the next person who ingests contaminated food or water. Entamoeba histolytica causes both intestinal and extra-intestinal disease. The disease process begins when a person ingests matured cyst. After reaching the small intestine, the cyst undergoes excistation, where the cyst wall breaks and releases multiple trophozoites. These trophozoites travel to the large intestine, attach to the colon wall using a special protein called gal or galnac lectin and begins destroying the tissue. They release enzymes called cytotoxins and proteases that breaks down the cells and causes tissue death. This destructive activity results in the formation of classic flask-shaped ulcers, which are deep ulcers with a narrow neck and wide base inside the intestinal wall. These ulcers can lead to symptoms such as abdominal pain, severe cramping, stools containing blood and mucus, appendicitis, tenesmus, which is the painful urge to pass stools even when the bowels are empty. It can also cause toxic megacolon. This is a condition where the large intestine becomes extremely swollen and enlarged. In some cases, the trophozoites penetrate deeper layers of the intestine, reaches the bloodstream, moves through the portal vein to the liver. Here they cause amoebic liver abscess, the most common extra-intestinal complication. The liver abscess typically occurs in the right lobe and causes fever, chills, and right upper abdominal pain. The patient may also have tender enlarged liver. The pus inside the abscess is often brownish and sticky, and it is described as resembling anchovy sauce. In rare cases, the parasite spreads to the lungs, causing symptoms like cough, chest pain, and reddish-brown sputum. Rarely the parasite reaches the brain, producing amoebic brain abscesses and presents with severe neurological symptoms and carries a high fatality rate. Laboratory diagnosis. The first step is stool microscopy, where fresh stool is examined under the microscope. The presence of trophozoites containing ingested red blood cells is a sign of invasive Entamoeba histolytica infection. Cysts with up to 4 nuclei may also be seen, especially in formed stools. However, as Entamoeba histolytica looks similar to non-pathogenic species like Entamoeba dispar, microscopy alone is not always reliable. Concentration techniques are laboratory methods used to increase the number of parasites, especially cyst and egg in a stool sample, so that they can be easily seen under the microscope. Trichrome staining is a permanent staining method to visualize intestinal parasites, especially protozoa such as Entamoeba histolytica, Giardia, and Balantidium. Antigen detection test such as ELISA is used to detect proteins specific to Entamoeba histolytica and differentiate it from other species. It is a very rapid and sensitive test and detects pathogenic Entamoeba histolytica specifically. Serology is very helpful in diagnosing liver abscesses because antibodies are almost always present in extraintestinal disease. Imaging techniques such as ultrasound and CT scan is used to detect liver abscesses and monitor their size. Additionally, in advanced laboratories, PCR test is used to detect parasite DNA and confirm the infection with high accuracy. Treatment of amoebiasis involves the following steps. First, an anti-amoebic drug such as metronidazole, tinidazole, or ornidazole is given to kill active trophozoites causing symptoms. These medications are highly effective in treating both intestinal disease and liver abscess. However, metronidazole does not kill cyst present in the intestine. Therefore, after finishing metronidazole, patients must take a luminal amoebicide such as paromomycin, diloxanide furoate, or iodoquinol. These drugs act inside the intestine and eliminate any remaining cyst, preventing recurrence and transmission. For liver abscess, most patients respond well to medications alone. Needle aspiration is only needed if the abscess is very large, at a risk of rupturing, or if the diagnosis is uncertain. So this is all about Entamoeba histolytica. I hope that the video was useful for everyone. Do subscribe the channel for more informative videos. Thank you for watching.